Okay, so it's 7 o'clock, and welcome to our monthly webinar. Good evening to everyone. So my name is Eva Bitte. I'm clinical psychologist, DBT and CBT therapist, professor at the University of Latvia, and I will moderate the webinar today. And of course, thank you everyone for joining us. So our topic today is eating disorders, and the session will last 1.5 hours. After the presentation, there will be time for questions, so please feel free to share them in the YouTube chat at any point, and I will read them later for Fragiscos, and we will answer your questions. So it's time for introduction. I'm pleased to introduce our speaker from Greece, Dr. Fragiscos Gonidakis, who is assistant professor of psychiatry at the University of Athens. And he currently leads the eating disorder unit and the dialectical behavioral therapy service at the Aeginetian Hospital. And Fragiscos has extensive training also in CBT and systemic family therapy, and of course in dialectical behavioral therapy. And he has created 2 distance learning programs focused on eating disorders and borderline personality disorders. And also he is the author of several Greek language books. And he is also international trainer and supervisor of DBT. And he was currently, just in May, elected as a member of the board of EDBTA. I think it's enough probably for introduction. So you are an important figure in this field, especially for eating disorders. And so now the floor is yours.
Thank you, Leva. Sorry. And we are going to talk today about a situation that we are we have to treat very often, and that is have a client that is suffering both from eating disorder and borderline personality disorder. And the idea behind the use of DBT to treat both conditions is that DBT, as we know, is a very effective treatment for emotional dysregulation. And we'll start with seeing and talking about the importance of emotional regulation and eating disorders. So we start with a few theoretical points. Emotional regulation is very important. It's very important to be able to have communities and societies. And emotional regulation has a lot of ideas and theories about how we can organize and regulate our emotions. You see one definition of emotional regulation back in 1981 by Gottsman and Katz. And one model that it is more modern, describing how we can regulate our emotion is the extended process model by Gross and Seps. That introduced the idea of 4 consecutive stages in emotional regulation. The first stage is to identify emotions and the need to regulate emotions. The second stage is to figure out what strategy I can use to regulate my emotion. The third stage is to implement this strategy. And the fourth stage is actually to monitor the outcome over time. That resembles the stages that we have in problem solving. And the extended process model is one of the mostly used model to at this point to understand emotional regulation. Another idea is having to do with emotional regulation is the 7 emotional regulation abilities that you can see in the slide. Impulsivity control is one of them, and we know that when we're treating people with borderline personality disorder, impulsivity is very important. And also the ability to implement emotional regulation strategies. That is actually some of the skills that we have in DBT. Now, we have adaptive mechanism and maladaptive coping strategies having to do with emotional regulation. But you have to have in mind that the latest literature data suggests that even maladaptive mechanism can be effective in very specific situation, and adaptive mechanisms sometimes are not very effective also in some specific situation. So, for example, if I am in a situation of extreme danger and I have to find a solution very quickly, suppressing my fear can also actually be adaptive. So if the building is on fire, I have a fear response to jump out of the window, but I live in the 5th floor, and if I jumped out of the window is actually a death sentence for me. I'm not going to survive. But my fear response is to get away from the fire as fast as possible, go to the other direction, and the other direction is the window. So suppressing my fear and trying to find out a way to put down the fire or navigate myself out of the apartment is actually a survival skill. So we have to have in mind that in most situations, problem solving, reappraisal, and acceptance is actually helping a person to regulate its emotions, but it's not always the case. So eating disorder can be regarded as a maladaptive emotional regulation strategy. And we'll see in a few slides forward why is that. Weiser and Tells introduced the idea that DBT treatment could be helpful in improving affect regulation, and so it can be helpful in dealing with eating disorder behaviors. So one of the first studies had to do with the use of DBT in persons and people suffering from binge eating disorder, not borderline personality disorder, just binge eating disorder. So we have a couple of RCTs showing that it's actually an effective way to deal with binge eating disorder in a group setting and teaching the clients the skills of emotion regulation, mindfulness, and distress tolerance. And my colleague Maria Karapatsia had recently published a study that was part of her PhD thesis that I had the honor to supervise, that online DBT for binge eating disorder can be effective also uh, to treat binge eating disorder. So there is a recent finding from a meta-analysis of data with adolescents suffering from eating disorders, showing that in females, emotional regulations issues are more likely to be associated with eating disorders. So we know that eating disorders are more frequent in females, and maybe for young girls and young women, eating and eating in an impulsive way is a way to regulate their emotions. And when they try to find out which um, of the factors associated with emotion regulation is more related to eating disorder symptomatology, they found out that it is emotional awareness. So most of the studies that were analyzed showed that when emotional awareness is very low, then it is more related to eating disorder symptomatology. So when we do emotional regulation skills and we teach our clients in mindfulness and emotional regulation skills to be aware of what they are experiencing, to be aware of their emotions, this is probably a way that DBT can help people getting out of using food as a way to regulate emotions. And a lot of our clients are telling us that they have never actually paid attention to how they were feeling. And when the binge eating or the bulimic symptomatology decreases, they start to be more aware of their feelings and actually deciding on the behavior that they are going to use based on their feelings and understanding their feelings. While before they got into treatment, uh, uh, any kind of emotional arousal, even a positive emotional arousal, could lead to a binge eating episode. So, why binge episodes are so highly reinforced as a behavior? Because when you eat a lot of food and sometimes when you purge, the levels of negative emotions decreases. And sometimes when you eat a lot of food that is actually very tasty, sweet food or salty food, the level of positive emotion increases. So it's actually a very efficient way to regulate emotion because food is available everywhere. Junk food is available through your app in your smartphone. It's not an illegal substance yet. You can order it, you can have it, you can taste it, and nobody's going to tell you what you are doing. And you can have it in your house. So it's very fast, it's very easy, and it actually produces an effect that you want. It for a short period of time, it regulates your emotion. So this is why it is so highly reinforced. Also, when I am binging and afterwards I feel bad about losing control or the amount of food I have consumed, and also I feel bad with having an increase in the fear that I'm going to gain weight, then my attention is removed from the actual events that produce the negative emotion that I have just regulated by eating. So I'm getting focused on the after effect of a binge episode, and I actually forget about what happened in my work, what happened in my family, in my relation. So this is actually another way to distract, and this is why also binging and purging behaviors are reinforced. One might ask what happens with anorexia nervosa. Well, with anorexia nervosa, when we starve ourselves, and this is an effect that doesn't have to do only with anorexia, it has to do with depriving yourself from food, then in the beginning, you have a hype effect. You actually have an increase in your endorphins, and you feel that you are in a state of euphoria. So there is an initial reinforcing of this state of euphoria and control that a lot of people suffering from anorexia nervosa describe when they tell us the story of how they were they got sick with anorexia nervosa. Also, when you try to eat something, you have an increased reaction of fear that you are going to lose control and you are going to gain weight. And this is actually one of the DSM-5 diagnostic criteria of anorexia nervosa. So in the beginning, I feel well, I am in a honeymoon, I feel that I am in control, I feel hype, I feel great. After a few months, I feel intense fear, even with the idea that I'm going to the kitchen and going to eat or prepare with myself a meal. In addition, people with borderline personality disorder that are suffering from anorexia nervosa, when they have their weight and nutrition restored, then the intensity of the emotions that they cannot regulate increases again, because when they were emaciated, then the level of experiencing emotions were lower. So when the weight and the nutrition is restored, they start feeling again, and they become extremely emotionally dysregulated. And that is a difference that we have observed from other patients that are not suffering from borderline personality disorder, is that when they get better, they feel better. They feel that the emotions are back, they feel in love, they feel joy, they feel like a human person again. Contrary to that, our borderline clients, when they have a normal weight and a normal nutrition, they actually, their mental status becomes worse. And this is why we have a very quickly relapse of the eating disorder symptomatology when we have people hospitalized for anorexia nervosa, and when they get out of the hospital, no matter how intense or how effective the psychotherapy was inside the hospital, they actually relapse very rapidly. And the idea of using DBT, but we don't have enough data on that yet, is that we have to teach the clients the skills of emotional regulation and distress tolerance as they coming out of anorexia nervosa, and as the weight is gradually and the nutrition is gradually restored. Now, let's go to DBT for borderline personality disorder and eating disorder. And DBT is adapted to incorporate eating disorder behaviors as part of the way that we are doing standard DBT. So we are talking about standard DBT, which is individual therapy, telephone coaching, skills training, and consultation meetings of the team. So we have to adapt the skills to focus also on eating behaviors. We have to adapt the diary card. We have to adapt the target hierarchy in order to also deal with the eating disorder symptomatology. And let me just say at this point that the Christopher Fairbairn's model on CBT for eating disorder is very effective, especially for bulimia nervosa and binge eating disorder, but especially for bulimia nervosa. So we use a lot of cognitive techniques that can be learned by Christopher Fairbairn's model. As you know, cognitive reconstruction and cognitive techniques is also part of DBT, but we put a lot more emphasis on skills training and problem solving and using behavioral modification strategies than cognitive strategies. But it doesn't mean that we cannot use part of the model that has already been proven effective for bulimia nervosa. So let's see at the beginning the treatment hierarchy. Most of you probably know the treatment hierarchy in DBT. We start with the pre-treatment, and the pre-treatment is very important, especially for clients that are suffering from anorexia nervosa, because As you already know, anorexia nervosa clients are experience a lot of ambivalence on the idea of gaining weight, restoring nutrition, eating more, while on this at the same time they ask for help and they want to become better and improve, but it's very difficult for them to abandon this strategy of emotional regulation. So pre-treatment is very important on dealing with eating disorders. The first stage is most of the treatment, as you already know. And the second stage is also very important because people that are suffering from borderline personality disorder and eating disorders, they have a high probability that they might have experienced some kind of trauma in their past, usually during their childhood and adolescence, and they need some kind of help with PTSD symptoms that are experiencing at the time when they are doing DBT with us. So we are dealing the last years, I don't know why, with more and more people that are coming for treatment that are suffering from PTSD, borderline personality disorder, and also from anorexia nervosa or bulimia nervosa. This third stage and the fourth stage of the treatment are well known to you. So what are we going to do with the behaviors that are related with the eating disorder? So we see not only the behavior, but also the function of the behavior and the context of the behavior. Meaning that if I am in a danger of dying from starvation, then starvation is a life-threatening behavior. If I'm very ambivalent with the treatment, I'm losing meetings, I'm not doing the skills, and I'm not coming to treatment, I'm not filling in the diary card because I have a lot of shame of describing my binge episodes, then this is actually a therapy interfering behavior. In any other case, then this is a quality of life interfering behavior. And let's say, for example, that anorexia nervosa symptoms is a quality of life behaviors. At the same time, I'm using drugs, I'm using cocaine, and at the same time, I'm self-cutting. So, according to the traditional eating disorder therapy, you have to deal with the eating disorder as a first. The first thing that you do in the treatment is dealing with the eating disorder. So you don't talk about any other stuff. You just talk about weight restoration, nutritional restoration, the mechanisms that reinforce eating disorders. But if we have a client with a lot of problems in the tier of quality of life, then maybe we will decide with the client that we have to deal with the cocaine first because it's actually creates more problem in the life of the client, or the client wants to get out of the cocaine abuse and then proceed with the anorexia nervosa behaviors. So it's not the traditional way of thinking when you are dealing with a client that is suffering from eating disorder. So it's the same with binge and purge. So if I purge 20 times every day and I have low potassium, then I might get a heart attack, and this is a life-threatening behavior. But if I'm medically stable, then this is a quality of life interfering behavior. If I'm not doing the homework, I'm not coming to the skills, I have a lot of guilt about binge episodes, and then it is a therapy interfering behavior. So it's the same with bulimia nervosa and binge eating disorder. We have to see how these behaviors that are related with eating disorders come into the life and the target hierarchy and what is happening with the client and what is his idea of therapy. Because at some point we have clients saying that, look, I've started with 2 hours of binging every day. And at this point, I'm having one binge a week. So according to the diagnostic criteria, one binge per week is still suffering from an eating disorder. But I'm okay with one binge per week. I don't want to lose that because it actually helps me regulate myself. I just want my binge. But now I want to talk more things about what I'm going to do with my life. I want to talk more things about the situation with my husband. I want to deal with self-cutting and all that. Are we going to abandon that? Is it okay to leave someone with one binge per week? This is the best that the client can achieve at this point and at this stage of treatment. So we have a lot of this dilemma arising into treatment. So this is why target hierarchy is very important in these clients that are suffering from borderline personality disorder and eating disorder. So I'll give you just a few minutes. I know that you are on YouTube and we cannot have a feedback, but maybe we can discuss it at the end. And I have put here a lot of behaviors that we actually see in people that are coming for treatment. So abusing laxative, compulsive exercise, of course, chewing and spitting food, abusing diuretics, self-harming, not lethal, not putting the person into a risk for his life. And sometimes we see sexual practices that have to do with violence, like BDSM, bondage, suffocating, and all that. So how would you target all this behavior? What would be first line for you? What would be second? What will be third? Of course, there is no correct answer, but I'll give you just a few seconds to think about what would you do with a client that actually describes all these behaviors that need to be targeted into treatment. And also have the opportunity to drink. Okay, let's go and see the diary card and the chain analysis. So this is the typical diary card, which of course we are not obliged to use. So when we have the diary card, we can add or subtract columns to fit the need of the client. So if we have a client that binges, we put columns for binge, urge to binge, vomit, laxative, compulsive exercise. All the behaviors can be put down in the diary card, especially the ones that we are targeting at this stage of the treatment. Sometimes when we have a lot of behaviors, we also use a food diary card and a DBT diary card. So they have to fill in, unfortunately, two diary cards. And the same goes with the back of the diary card when they circle what kind of skills they used during their week. So I'll show you some of the diary cards that we use. Let's say, for example, that we have a client suffering from bulimia nervosa. we have a diary card, a food diary card that comes out of CBT treatment for eating disorders. So we put down the time of each meal, the place, and also if the client is sitting or is standing, because some of the clients that are having bulimic episodes, they are standing and eating, which is not very helpful with mindful eating that we want to teach them. What was their meal, if they have an intense urge to binge, whether they binge or not, if they vomited, and sometimes in an extended diary card for bulimia nervosa, we can put also the intensity of the emotions that they were feeling, what happened during the binge, and all that. With anorexia nervosa restrictive type, of course, the columns are less, but we can have also special notes on how many hours they were exercising, what kind of exercise they were doing, and whether they had some other kind of behaviors like chewing a lot of gum or chewing food and spitting the food and all that. And this is also the same with anorexia nervosa binge purge type and binge eating disorder. So we put an emphasis on what is happening with their food, which is very important in the treatment of eating disorders, while at the same time, we use all the information from the DBT diary card that we want to have in order to organize individual therapy and what to target and how to work with the client during the session. So also in DBT for eating disorders, we have all the behavior strategies for nutritional restoration, gradually increasing the meals per day and enhancing meals with the forbidden foods, and also teaching the clients to find alternative ways of regulating their emotions. So what we are doing is based on the idea, and also this is not also an idea, it's also an observation, a clinical observation, that usually a binge episode arises from two paths. One path has to do with starving myself, being on a diet, trying to lose weight, trying to regulate my food intake by eating healthy foods. That is usually it's not healthy food, it's food that has a low caloric intake, and trying to eat as less as possible during the day. And the other path is experiencing intense emotions that I don't know how to regulate. So I need to restore the way I'm eating in order to decrease hunger and the urge to eat, and at the same time work with my emotional regulation skills in order to be able to tolerate and regulate my emotion in a different way than using food to do that. Of course, when I'm having a binge episode, I need to understand what happened, what were my vulnerabilities, what were the chain of events that led to a binge episode, and also what were the consequences, because sometimes the consequences are the reinforcing factor of the binge episode. I feel more relaxed. I ate as many food and I didn't gain weight because I purged, and that's actually reinforcing me. I restricted, I skipped a meal, and I felt very good with myself. I felt proud of myself. I felt that I have the power to regulate myself, and that actually reinforced me to continue doing that. My fears of gaining weight were reduced. I was able to deal with a difficult situation with my wife or my kids I didn't shout to them. I didn't make any nasty comments. I just endured the pressure coming out of my family situation. And that was actually done because I binged and then I felt sleepy and I went to bed and it was over. And that's actually reinforcing my binge episodes, especially when I use a lot of conflict avoidance strategies to cope with emotional difficulties and difficult situations. So you see with anorexia nervosa, different consequences, with bulimia nervosa, different consequences, with binge eating disorder, sometimes different consequences. And all these data are coming out of chain analysis. But instead of chain analysis of another behavior like self-cutting, now we have chain analysis of behaviors that have to do with eating disorders. So if you will, at this point, we'll make another short break to think about a chain analysis of a binge episode. So just give it a few seconds to have it in your mind, or you can put it down into a paper. Why a client of us would end up having a binge episode? What might be the vulnerabilities? What might be the chain of emotions and thoughts, and what facts, what happened, and it started to have the urge to eat, and what would probably happen afterwards. Okay, let's see the adaptation of skills and telephone coaching. Telephone coaching can be used to help people avoid a binge episode, or using the skills to prevent any kind of maladaptive eating behavior. And just let me remind you here that we have an adaptation of DBT introduced by Thomas Lynch called Radical Open DBT, that has to do with people that the main problem is intense regulation of emotion. They are over controlling their emotions. While with borderline clients, we have an under control of emotions. With compulsive clients or people suffering from anorexia nervosa restrictive type, we have an over control of the emotion. So radical open DBT is an adaptation of DBT for people that are over controlling their emotions. But we are talking today about people that have under control of emotions and they are suffering from borderline personality disorder and eating disorders. But radical open can be used for people suffering from anorexia nervosa restrictive type, because most of the people that are suffering from borderline personality disorder, they don't suffer from anorexia nervosa restricting type. Usually they suffer from bulimia, binge, or anorexia nervosa binge purge type, because they are more impulsive. So usually at some point they lose control and they eat a lot of food and they purge. So we start with mindfulness, and the adaptation for eating disorder is that we introduce the idea of mindful eating. Mindful eating is not exclusive on DBT, as you might already know, is a well-established way to be more mindful when you are eating and actually enjoy your food in a more satisfying way. So everyone can practice mindful eating. You don't have to eat slowly. You don't have to chew slowly. It's just when we're doing mindful practice with mindful eating, we ask people that are doing the practice to eat more slowly. You can eat in your own rhythm. You can eat as fast or as slow as you like. But the important thing is to be able to be mindful of the taste and the smell and the experience of food, avoiding doing a lot of things at the same time. And we know that multitasking is a scourge of our time and our society. And a lot of people in the past, they were eating in front of the television. Now they're eating and they're having their iPhone or their telephone with them, and they are going through Instagram, TikTok videos, or the news or something else. So they get distracted for the experience of food, and usually this leads to feeling unsatisfied. And when I'm unsatisfied, I'm not saturated, and usually I eat more food even if I don't binge. So mindful eating is very important. So when we are teaching mindfulness skills, we ask them to observe their feelings, to observe when they are full, to start to distinguish between being hungry and being thirsty, because we know that a lot of people that are binge eating, they mix up thirsty with hunger, and they eat when they actually feel thirsty, and that leads to an increase in their weight. To observe when they are full and they don't need to eat more food, so that they don't eat in a compulsive way to empty the dishes or empty the containment of chips or all that. In interpersonal effectiveness skills, we teach them how to say no to invitation that might lead to a binge episode, how to increase self-respect, and how to ask others for help. So sometimes I need, in order to avoid a binge episode, to eat and go out with dinner with a friend, because it's more easy for me to avoid binging. Also, in anorexia nervosa, sometimes the parents are very helpful, because when they eat with the client, they help this client to distract from all the compulsive thinking about the calories and how fat they will become if they complete their meal. So having the mother, the sister, the sibling, or some other person sit with you and discuss with you is very helpful, but you have to ask. You have to overcome this idea that it's very bad to ask for help. So teaching the interpersonal effectiveness help a lot. It helps also with asking, for example, your parents or your spouse not to have a lot of candy inside the house. At the beginning, we have to do some kind of stimulus control to avoid binge eating. So not having a lot of candy, not having a lot of food that can trigger a binge episode is very important. But I have to ask the other people that are staying with me to avoid stocking large amounts of food in the house. Also, with emotional regulation skills, which are very important, we teach the client to observe and label and regulate their emotions, and also to treat emotional avoidance, as I discussed a few minutes earlier, which is very important in order to avoid binging. And also with distress tolerance skills, we teach them to surf the urge and manage intense emotions without going to the fridge to eat something or to snack or to order something through the applications in their phones. So dealing with intense emotions, dealing with difficult situations without binging is very important, and that has to do with using all the distress tolerance skills that we teach in DBT, but especially we use the surf the urge skill. So surf the urge, meaning that you have to radically accept that you cannot stop the wave. You cannot stop wanting to eat and to binge. This is something that might come, and you will not be able to stop that. But you learn how to surf. You learn how to deal with this intense urge, this impulse to go to the kitchen or to grab some food or start eating, and experiencing the emotion without doing the behavior. So you see the four stages of surfing the urge meditation. We focus on the area when we are experiencing the craving. Is it in the mouth? It's in the belly? It's something here. Sometimes I feel a little tremor in my hands, or I have images of the food, or I have memories of how hedonistic is the food. The second stage, I acknowledge that I'm going to experiencing the craving. It is what it is. It's happening. It's what I'm experiencing right now. On the third stage, I start to try to focus and in other parts of my body and have a more holistic image of my body. And if my mind goes back to the craving, which is quite important, then to be able to go to another part of my body that is not experiencing the craving, and being able to regulate my breathing, because regulating my breathing regulates the stress. Because if the stress levels goes up, at some point I will not be able to avoid the binge and I will binge. So let me tell you that surfing the edge is not the solution to avoid the binge eating episode. We are dealing with people that are extremely dysregulated. It's one of the skills that we try to teach them. Sometimes it helps, but sometimes they have to use more skills, even the tip skill, to avoid binging. Of course, opposite action is something that it is very helpful, because I have to actually do exactly the opposite of what my mind is saying. So my mind says that you are very tired, you had a very intense working day, you did a lot of things, and you deserve a reward. And the reward is eating one pizza and then eating a box of ice cream. And if you do that, you are going to feel very nice. You are going to feel satisfied. You are going to feel good with yourself. And you are going to feel relaxed. The tension will go down. But I know with my wise mind that my weight is going to increase, and afterwards I will feel bad with myself. My self-respect will go down, and it's not helping my high cholesterol. So I'm putting my life into danger on the long run. So I need to be able to notice and observe all these thoughts and ideas, all these memories of how intense is the satisfaction from the pizza and the ice cream. I have to observe all the urges and all these thoughts in my mind. I deserve it. I had a very bad day. I need to have some kind of reward. It's my time. It's night. I cannot do anything else. I can't sleep like that. Carrots don't taste as beautiful as ice cream. And I have to find a way to relax my body and to avoid going to the kitchen, because sometimes I get scammed by my own self that says, you can go to the fridge, take the box of ice cream out of the fridge, and just have one spoon of ice cream. It's just one spoon of ice cream. You will be able to stop afterwards. Well, I don't know about you, but it has never happened to me. If I start eating the ice cream when I'm experiencing the urge to binge, I'm going to finish all the ice cream. So I have to do exactly the opposite of what my mindset. I have to sit in my beautiful couch, drink my water, think about something else, listen to relaxing music. I have to find another way to satisfy myself. But I have to avoid going to the kitchen. I have to avoid going to the fridge. I have to avoid taking the first spoon of ice cream. Because if I do that, and it is the same with addictions, then my limbic system is fired and I will not be able to stop. But at this point, my wise mind doesn't work and it doesn't remember what has happened the last 2000 times that I went to the fridge the last 20 years that I'm suffering from binge eating disorder. So we'll do 1 minute of mindfulness. We leave everything as we are and we'll just observe how we're feeling right now. Are we hungry? Are we a lot of hungry? Are we okay? We're full. If I'm hungry, what is my body sensations? And observe that, doing nothing else just for 1 minute, starting from now. Okay, well, it's close to 9 o'clock in Greece, so a little bit hungry, probably. Okay, now the last part of the skills has to do with the skills in the skills book in the stress tolerance section that have to do with drug addiction. So I know that Marcelina have produced that skills and include them in the latest skills book, because at that point there were a lot of evidence that DBT can be used with drug addiction, but we can use these skills also for binge eating behaviors, and I find them very helpful, and also my clients find them very helpful. So we're not going to go through all the skills, but let me remind you two of them. The one is the synthesis of the dialectical abstinence. So when I'm out and I'm not binging, I have to keep my commitment to avoid binging, and also I have to plan with what I will do and how I will react if at any point I will have a relapse of the binge eating. So I'm never going to tell myself that I am out of the binge, because we know that this kind of behavior are highly relapsing and they come and go through the whole lifetime of a person that has suffered from eating disorders. But when I am relapsing and I had a lot of bulimic episodes, I have to have a plan and use my plan how to get out of this relapse. But at first, I have to accept that I am in a relapse. It is okay to have a relapse because I cannot control everything in my life, and commit to get out of the relapse as soon as possible. So, what we are seeing with a lot of our clients is that they um, what they are having at some point is that they have 4 days of intense binge episode and then 2 weeks that are out of the binge episode. 2 days staying in the house, eating and purging the whole day, and then 2 weeks, 1 week, 1 month, 3 months out of binge episodes. And I see a lot of this in people suffering from borderline personality disorder. And even when the rest of the borderline symptoms have remitted, they still have these relapses of the binge episodes. So these kind of skills are proving to be very helpful with people that have become extremely more well, but not well enough to be fully remitted. And it is important for them because they are building a life when they have a job, they are studying, they have a romantic relationship, they have friends. They have to get out of this condition when they stay inside the house with the phone put to aeroplane mode, eating and purging the whole day. They have to get out of this situation as fast as possible because it's very important to them not to have this kind of disruption in the life that they are trying to build. And the second idea is the idea of the clear mind. So I find also this very helpful. So when I am binging, I'm actually in the addict mind. So I'm very happy. I'm eating a lot of food. I can eat as much as possible. It's okay. A lot of people are doing it. I can cut it whenever I want. So this is the addict mind. But when I'm out of the binge episode, then sometimes I get into what is called clean mind. Over. It's over. It's never going to happen again. Thank God I've done it. Thanks to my therapist that helped me do that. Thanks to DBT, CBT, DBT, or something like that. So I never deal with a situation that at some point in my life, in the future, I might have a binge episode again. I don't have any kind of plan. So what I do is that I actually get into situations that can trigger a binge episode. For example, I have an invitation to my friend Leva. I go to her house, and Leva is an excellent cook, and she has a lot of recipes from Northern Europe that I like. And I haven't eaten anything during the day, just a coffee and a toast in the morning. So I'm extremely hungry, and I run the risk, even if I am remitted, I run the risk of eating a lot of food. And then I run the risk of having this idea that now I might get fat. And then having another idea that, well, it's now 2 years that I haven't purged. If I purge a little bit just to get this food out of my system, then I won't gain weight. And of course, because now I'm 100% okay, I can deal with this situation. I have the control. And we know that it doesn't work like that. It doesn't work like that with drugs, and it doesn't work with that with food. So I have to retain a state of um, a state of clear mind when I know that I have to pay attention, I have to use my skills, I have to do my mindfulness practice, that binges can come back, anorexia can come back if I get into a diet and I start losing weight for a month, then all the anorectic compulsive way of thinking will come back. So I have to be prepared. And also when something like happen, I have to be prepared to act as fast as possible to get out of this situation. Ask for help, come in touch with my therapist, read the skills, start doing practice again, and this is actually helping. So I don't think we can do this exercise. And I'll finish with a few results from the studies that we have so far on DBT. I won't bother you a lot. I know it's already getting late. So we had research until now that shows that dialectical behavioral therapy can be used for people suffering from borderline and eating disorders. Just bear in mind that we don't have any kind of research that says that dialectical behavioral therapy can be used for people suffering from anorexia nervosa binge purge type. I mean, we have a little bit of some kind of implication that it can be helped, but most of research is done with people suffering from binge eating disorder or bulimia nervosa. This is recent research that shows that a comorbid diagnosis of borderline does not impact eating disorder treatment outcomes. And at the end of the treatment, there was no difference between the two groups. They use DBT for people suffering from eating disorder and borderline, and for people suffering only from eating disorder, which is a very nice result. And there is another research with that they were hospitalized with it's a very large number for research on psychotherapy. And you see, this is also what we are observing, that while the clients that are suffering from borderline personality disorder, they will improve with DBT, they have more remaining eating disorder symptoms. They are still having bulimic episodes that they cannot actually stop. And we have the same also clinical experience with our clients. And finally, that's a small research done by my colleague Filiakopoulou as part of her PhD thesis with clients that are suffering from borderline personality disorder and eating disorder, not from binge eating disorder, but from anorexia nervosa and bulimia nervosa or bulimic type eating disorder. And one of the things that I want you to observe is that 76% out of 91 completely to 1 year of treatment. That was only 16.5% dropout rate, which is extremely, extremely low for people suffering from borderline and eating disorder. And that has to do with other results in the literature that says that when clients, even with severe cases of clients having treatment with specialized therapists, that they actually know what they are doing and they are motivated to help, and they actually have a therapeutic strategy that actually can help, then there is a less possibility of dropout. So these people were doing treatment with people that were trained in CBT for eating disorders and in DBT, and they had a lot of years of experience of treating borderline clients that were suffering also from eating disorders. And that is, I think, the reason why we had a very low dropout rate. And this is very promising if we can replicate this kind of result. Is very promising for having a, a programs, treatment therapy programs in university hospital or in state hospitals that are DBT informed or DBT programs dealing with these comorbid situations that are very often. I mean, we are getting more and more people suffering from borderline personality disorder and eating disorders. So that's some of the results. We have seen we have seen improvement in both scores, both on the measurements that are that are measuring borderline personality disorder, like BSL 23 and DBT ways of coping, but also in the measurements of eating disorders using EDQ. And these two measurements were also correlated together, meaning that probably when we're using DBT for eating disorders, both the behaviors that are related with borderline personality disorder and eating disorders are reduced at the same time. And that is quite interesting when compared to other research that were using non-specialized treatments that were showing that if you are very focused on eating disorder symptomatology, you don't get a very good effect with borderline symptomatology. But when you are focused on borderline symptomatology, you don't get a reduction of the eating disorder symptomatology. And that's why we try to further our research and find out whether DBT can be an effective treatment and how effective treatment can be for people that are suffering from eating disorder and borderline personality disorder. So I think that's the end of it. And I think that we have some time. And let me please move inside because it actually has gotten quite dark and I don't see you can actually see me
Yes.
anymore. So I think now it's better. Okay, sorry for that.
Yes, thank you, Fragiscos. We have one time zone. It's 9 o'clock in the evening, so it's probably getting darker. So, thank you for your really wonderful lecture and really inspiring results. And I think it's really so important to address both eating disorders and borderline symptomatology. So, it is very, very inspiring. Um, so, there is one, not so much a question in a chat, but a statement. Another dialectical dilemma from Jeremy Mostert. Apparent compliance versus active defiance. Research in eating disorders have identified another dialectical dilemmas. Um, do you have some comment on this?
But parent compliant.
Apparent compliance versus active defiance.
Okay. I don't know about, of course, the people suffering from eating disorders, they have a lot of conflict with the family. And of course, there is a dialectical dilemma in that. And if we remember the distress tolerance skills on drug abuse, there is a skill that calls alternative rebellion. So we'll try, if they need to rebel against the family, which is quite normal in adolescents, we need to help them find another way, more important and more effective way to rebel against the family. Because it is more, this is my idea, and sometimes I discussed it with some of the clients. If I rebel against my parents and say that I will do the job that I want to do and I will study what I want to study, not what you are pushing me to study, which is very often in Greece, to be honest. And this is a way of rebelling and gaining my self-confidence that is going to move me forward. I'm going to the next step in my life because I'm studying, I'm choosing my own friends, I'm making my own mistakes. If I say to my mother or to my father, I'm going to eat whatever I want, and you are not going to dictate to me my diet. So what kind of moving forward is that? I mean, it doesn't, it's just always playing defense. It's no offense. And this is why we see people suffering from anorexia and having the same fights again and again for decades with their parents, while at the same time, they haven't moved forward with being independent, being autonomous, or leaving their house. We have 40 years old clients fighting with their old, very old mothers, third age mothers, about the same things that they were fighting 20 years ago. So that's the problem with eating disorder. It doesn't move you forward. You are not going on with your life. And if you find an alternative way to rebel, this is a way to get out of this dilemma because I will do what you are telling me with eating, because the mothers tells the children that you eat to eat more. So I will comply with that, but I will have another way of rebel against you in other things that are more important in life. I don't know if that makes any kind of sense or not.
Yes, sure, absolutely. It really makes sense. Yeah. And so another question, probably similar one, and there is one more also. So how do you teach skills for clear mind? Do you have probably some examples?
Um, okay. Um, we teach them in skills training, but we also teach them in individual therapy. So I don't know if I can give you a different example from what I have said, but usually I tell them this kind of example of a friend that I go to the house and I am very hungry and it's probably going to eat more. We usually also use example by the clients. Um, I use an example of again going to a house. And we usually in Greece, when you go to the house, you have to bring a bottle of wine or some sweets or something like that as a treat. So I choose a road that goes through my favorite pastry shop. When I had a lot of binges in the past, I was buying pastry from that shop. So I don't pay attention to the route that I'm choosing because now I'm well and I don't have to pay any attention to what I eat and I don't eat and how to avoid things and all that. So I go through the pastry shop. I'm hungry, of course, and I smell the smell of butter outside. And I say, oh, I have forgotten to bring some sweets to my friend who has invited me for dinner. So I go inside and buy some sweets because I'm not going to buy anything that can cause a binge episode because I'm well now. So I buy, let's say, half a kilo of sweets, and then I see something that reminds me of how nice and how tasty is this sweet. And I say, okay, maybe I'll grab one and eat it on the road as I go to my friend's house. So I'll have the box and I'll have an extra one and I start eating as I'm walking. And then all the memories are triggered in my mind. And I sit in a pavement, in a park, or some in a bench or something like that, and I eat all the sweets because they are there, they are available, and I can do it. And then I go in another shop, I buy a bottle of wine, and I go to my friend's house, but I have already started a binge episode. And that comes out of a few, they seem irrelevant decisions about which road I'm going to use, what kind of gift I'm going to bring, because I'm not suffering from, if I was suffering from alcohol abuse, I should probably buy some pastries. If I'm suffering from binge episode disorder, it's better to buy flowers or to buy a bottle of wine. But I choose to buy pastries because I go outside of my favorite pastry shop and I have totally forgotten that this pastry shop is my drug dealer. And so I go in front of the drug dealer and I'm definitely going to have a relapse. But I don't believe that. An example of clean mind. So an example of addict mind is that I'm inside the house, I had a binge episode, I feel totally discouraged, I have totally forgotten that I know and I have the skills how to get out of this situation. I have done it at least 10 times in the past. So I get into this mood dependent state that says I'm never going to get well. I am cursed. I'm going to live like that. I'm worthless. I have achieved nothing in my life. The therapy doesn't work. So I just negate any kind of success that I had in the past. I negate all my wins, all the things that I have learned. So I'm not going to use my skills. It's going to take me a lot of days to get out of the situation. I'm not fighting to get into abstinence again. And this is what I have to remember, to have posts, to have everything arranged if I get this kind of relapse. And this is the addict mind that just gives up and is completely overthrown by this tsunami of emotions and behaviors.
Okay. Yeah. Thank you. So it was very nice explanation. So Jeremy, who asked about dialectical dilemmas, uh, wants to specify a little bit the question. So regarding, and I put it also in the Zoom chat. So
Yes.
apparent compliance, clients reports engaging in sufficient amount of behavior to demonstrate effort, but does not engage in it enough to make appreciable change. And active defiance, behavior that is willful and in opposition to treatment recommendations, refusing to follow treatment recommendations or program limits. So how do you deal with that?
Okay. I'll start with compliance. So
Mhm.
it's it's um, it's very difficult to deal with eating disorders. So we have to radically accept that some of the clients are doing the best that they can. They are getting the correct treatment. We are doing the best that we can, and they still don't get better. And it's not that they are not putting a lot of effort. It's food and eating. It's the problem is that it is in the basis of our genetic material. We are hardwired to eat. And it's very difficult to stop something that has to do with the natural need, or it has to do with how our body works. It's not that I am trying to stay out of cocaine. I mean, I will avoid all the people that are using cocaine. I'll change my friends. I'll change my name. I'll delete the names of the drug dealers from my phone. I won't go to parties. I've stopped going out to parties. I'm not going to clubs and all that. I can do that. How can you avoid food? I mean, you can't avoid food. You have to regulate food. So it's more difficult. It seems that it is more easy because everyone is eating, but it's actually more difficult for them. So we have to acknowledge that they are doing the best that they can, but sometimes it takes more time. And sometimes what we see with eating disorder is that we don't get a full remission. And let me tell you an example. There was a very interesting study in 2019 that was it took all the open trials on CBT for bulimia nervosa. Open trials is actually what is happening in our clinical practice. It's not randomized controlled trials. You don't control the sample. You are not working in Oxford with Christopher Fairbairn. You don't have controls. You don't have highly experienced or highly supervised therapists. It's what's happening in our hospitals or in daily life. And it showed that only 40% of people that were suffering from bulimia nervosa were fully remitted. Fully means nothing, no symptom at all of bulimia nervosa at the end of treatment. So while the RCTs on binge eating and CBT for bulimia nervosa showed a very high effectiveness, something like 70 to 80% full remission. In actual life, the full remission was 40%. So I was actually relieved when I read this paper because I was feeling like I was completely useless as a therapist because this 40% full remission is actually my clinical experience. So it's very difficult, and this is why we try to find different kind of techniques, different kind of strategies, different way of coping with that. But it's very difficult because when you start to eat, and you have to eat on a daily basis, it's very difficult to use all the skills and the mindful eating and what you have practiced. So sometimes we don't get any kind of change. And this is why we try to change the treatment and use different and sometimes we have different treatment modalities combined together. You get group DBT and CBT, or you get systemic family therapy and CBT, which is very common. Because actual eating disorders are very hard to treat. And of course, there are not any kind of very effective medication to help you with that. And the second is active defiance. Um, well, I think that's probably our everyday life with people suffering from borderline personality disorder. I don't, when we have a client that is actually defiant, and if you say that's active defiant, then we have to go back to the pre-treatment stage and talk about commitment to the treatment. Because if CBT or DBT is very is very unpopular with some clients, then we need to think about what else we can. So if somebody says, I'm not going to try, I'm not going to do the diary card, I'm not going to do that, and that, when we have to do some kind of chain analysis to understand why they become so intense defiant to the treatment, what is the thing that we cannot understand. Sometimes it's us. We are doing the therapy interfering behavior. We can't understand how difficult it is for them. We can't understand things that they're telling us. So if my father is touching me in a weird way and I am 15 years old, I'm trying to tell you that. I'm trying to tell you that I cannot eat. I need to be very slim because I have this kind of situation in my house, and you actually put me in an effort to reduce starvation. Actually, you are not hearing me. The problem is that I am probably molested by my father, and we have to do something about that. We have to intervene to the environment instead of trying to do treatment. So we have to check therapy interfering behaviors, we have to check commitment, we have to check all that to see why the client is getting so much defiant against us and the treatment. So, sorry,
Yeah.
I can't hear
No,
you.
thank you. Yes. There is another question from Paola.
Got it.
In restrictive anorexia nervosa, there are no clear loss of control or impulsive behaviors. How does DBT treatment differ in this subtype compared to other eating disorders, especially in the use of tools?
Okay. We don't use DBT for anorexia nervosa restrictive type because of what Irena said. Sorry,
Mhm.
that's the name. Um, that is why I told you that there is an adaptation of DBT
Mm.
called radical openness, which is quite different from what we are doing in DBT because it has to deal with over control of emotions. While in borderline, we have the under control of emotions. So DBT and what I told you today is not actually helpful with clients suffering from anorexia nervosa restrictive type.
Yeah. Okay. Yeah. So it seems there are many thank yous. So for the interesting lecture and very helpful examples. And also from Jeremy, thank you for explanations of the dialectical dilemma. Sounds like commitment strategies are also more important, which is probably true. Yeah, so great lecture and thank you for it.
Thank you also for having me, and thank you for organizing all that because it's quite different from Zoom trainings because everyone is in YouTube. So thank you for being here and coordinating all the webinar.
Okay. Yeah, so actually, yeah, it seems that that's it from chat, but actually from informative lecture also. Actually, I still have one question in my head, and
Okay.
I think what I am struggling with, if to think about patients with eating disorders, so it is the very strong critical voice or thoughts which are they having. So, do you have some recommendations how to deal with it, or maybe, yeah, some ideas?
So can you elaborate more on
Yeah, it's like I think I meet really, at least in Latvian patients, it is really extremely strong, like criticizing themselves, either they eat or don't eat. So of course, all those concerns about shape and weight, but not only. So like extremely, maybe because of severe abuse episodes or other difficulties. So it is really extreme. Uh,
So, what we actually try to do is, of course, we try a little bit of cognitive reconstruction and how to deal with very judgmental and critical thoughts. But at the end, what they have to radically accept, which is very difficult and it takes a lot of time, is that you are not going to be satisfied with your body. And that's a reality of life that has to do with the society and how much important inputs on slim, not real bodies that you can see in Instagram or TikTok or something like that. And a lot of clients says that I know now that I will never be satisfied with my body, but it's nice that I can do things with this body. I can understand that I can be loved even if my body is not perfect, is not very extremely slim. So they changed the the predictions. They predict that if my body is not like that, then I won't be doing that and that. So when they start doing opposite action and they start avoiding, sorry, they avoid the avoidance and they stop avoiding, then they get results that they don't have even predicted. When they become more mindful and they see that, for example, the boyfriend actually likes them, is sexually aroused by them, flirts them. So they haven't paid attention to that. So when they become more mindful of the situation around them and of the moments that they experience love, they experience the emotions of being connected, while at the same time they have a critical mind said, don't let him touch you because you're fat. If he touches your belly, it's over. So they have to be supported in order to do opposite action and let, for example, the boyfriend touch the belly. And when nothing happens, he's not disgusted. He doesn't go away. He doesn't say, "Yeah, I never want to touch her again in my life." Then this is a proof that they can use to continue fighting the avoidance. So it's actually behavioral change. You have to go to the
Mm.
system and wear your bathing suit. You don't wear your hijab because they go to the beach, and in Greece we have a lot of beaches, and they go to the beach and they wear a hijab. They wear long clothes, something in their head, a long skirt, and they just go inside the sea for a couple of minutes, have a quick bath, and then out wearing the armor in order to avoid the disgusted this is disgusted faces of other people that will observe her. So when he gets a lot of support to try and experiment and do exactly the opposite and nothing happens, it's like having a revelation for some of them, because for some other it never changes. It's very strong, it's very embedded in their own way of thinking. So no matter what we try, they will never expose themselves to do opposite action. So
Okay.
it's very difficult to change all these beliefs if you don't do exposure.
Mm. Hmm. Exposure and radical acceptance also. And so it's, yeah, sounds
I-
great.
it's the whole skills.
Yeah. Okay. Okay. So thank you. Thank you so much. So our time is really over. And thank you. The lecture was really interesting. So fascinating webinar is the last response. So thank you, Fragiscos. And yeah, have a nice evening.
And have a nice summer for
A nice
both
summer.
of you.
Okay. Okay. Thank you.
Bye.
Bye.
Bye.